You know those tiny little creases on a newborn's legs? Ever notice if they look a bit, maybe, uneven?
Hmm.
It might seem like such a minor detail, but today we're doing a deep dive into a condition that can start with just clues like that.
Right?
And it can have a real impact on the road. Developmental dysplasia of the hip, or DDH.
Exactly. You might also hear it called congenital dislocation of the hip, though DDH is the broader term we tend to use now.
Okay, DDH. And for anyone tuning in, maybe for revision, wanting to really nail down this topic.
Yeah, our goal today is to really unpack DDH, everything from what it is, the causes, how you spot it, how we manage it.
Basically give you a clear, high-yield overview.
Precisely, make it memorable.
Okay, let's get right to it then. DDH.
Mm.
In plain terms, what's the core issue here?
Well, think of the hip joint. It's a bowl and socket.
Right.
In DDH, either the socket part, that's the acetabulum, doesn't develop properly, it might be too shallow,
Okay.
or the ball part, the femoral head, isn't sitting snugly, properly aligned within it.
So it's an abnormal development.
Exactly. And it's a spectrum. It can range from quite mild, just that shallow socket, what we call acetabular dysplasia.
Like a golf ball not quite sitting right on the tee.
That's a great analogy, yeah. Makes it wobbly, unstable, all the way to the hip actually slipping out, either partially or fully. That's subluxation or dislocation.
And it's not always obvious right at birth, you said.
No, that's crucial. While we typically find it in neonates, the signs might not be apparent immediately. It can develop or become more obvious later.
Got it. And it's more common in girls. I remember reading that.
Yes, definitely. That's a key point. About 6 times more common in girls than boys.
6 times. That's significant. Any idea why?
It's thought that hormonal factors might play a role, maybe influencing ligament laxity around the time of birth, but it's quite striking, yeah.
Okay. So what actually causes this? What sets this abnormal development in motion?
Well, it's rarely just one single thing. We call it multifactorial.
Multifactorial. Okay.
So there's often a genetic predisposition. If it runs in the family, the risk goes up.
Right.
Then how the baby is positioned inside the womb, fetal positioning, that's a big factor.
Mm-hmm.
And also mechanical factors during development or even around birth.
So a combination of things potentially coming together. Now, who are the babies we need to be particularly watchful for? What are the sort of red flags or risk factors?
Okay, yeah, there are several well-established ones. Being female, as we just discussed, is a major one, about 80% of cases.
80%. Wow.
And interestingly, firstborn children are also affected more often. Around 60% of cases are firstborns.
Firstborns. Why is that thought to be?
Perhaps a tighter uterine environment the first time around, maybe less space. That's one theory.
Okay. What about the delivery itself? Does the type of birth matter?
Oh, absolutely. Breech presentation when the baby is bottom or feet first, especially during vaginal delivery, massively increases the risk. We're talking about a 17-fold increase.
17. That's huge.
It really is.
Mm-hmm.
And even if a baby is breech and delivered by an elective C-section, the risk is still elevated, maybe around 7 times higher.
So the position before birth is key too.
Exactly. And linked to that is oligohydramnios, having low amniotic fluid.
Ah, right. Less fluid means.
Less room for the baby to move around. That restricted movement might hinder normal hip development.
Makes perfect sense. Anything else on the risk factor list?
Yes. Multiple pregnancies like twins or triplets. Prematurity is another one. And certain neuromuscular conditions can be associated with things like cerebral palsy, spina bifida, or arthrogryposis.
Okay.
And there's an interesting link for DDH that's picked up a bit later, say after 3 months. It seems to be associated sometimes with cephalic, so head first, deliveries, and also certain traditional swaddling practices.
Swaddling, how does that fit in?
If the baby's legs are wrapped tightly straight and held together in adduction and extension, that's not the natural frog leg position for hip development. We'll come back to that in prevention.
Right. Okay. And family history.
Yes, definitely. If a baby has a sibling with hip dysplasia, their own risk increases by about 5%. So always ask about family history.
Good tip. So let's drill down into the pathophysiology. What's actually going wrong in the hip joint itself?
So the fundamental problem is that inadequate growth or misalignment. The acetabulum, the socket, fails to deepen properly. It doesn't form correctly to fully cover and contain the femoral head, the ball.
So it's a poor fit, essentially.
A poor fit leading to instability. The ball isn't secure in the socket.
Okay. Now, if you're examining a baby, maybe you find something suspicious, what else could be causing hip issues? What are the differential diagnoses we need to consider?
That's a really important question in practice. You need to rule out other possibilities. Things like transient synovitis, that's a temporary inflammation, often after a virus.
Uh-huh.
Septic arthritis is a serious bacterial infection in the joint itself. Very important not to miss that.
Definitely.
Then there's leg calf Perthes disease, which usually presents a bit older, affecting blood supply to the femoral head. Muscular torticollis, the neck issue, can sometimes cause asymmetry that might confuse the picture. And of course, as kids get older, any other cause of hip pain or limp needs consideration.
So keep an open mind. Okay, let's zoom out again. How common is DDH? What's the epidemiology look like, say, in the UK?
It affects roughly 1 to 3% of newborns here in the UK. So, it's relatively common.
1 to 3%.
Yeah. But what's really striking and highlights why early detection matters so much is its contribution to later hip problems. DDH is responsible for a significant chunk, around 29% of primary hip replacements in people under 60 years old.
Wow, nearly a third of early hip replacements. Yeah, that really drives home the importance.
It absolutely does.
Does it favor one side?
It does, yes. The left hip is affected more often than the right.
Left hip. Any reason for that?
The most common theory relates to fetal positioning. Again, the typical lie in the uterus often puts the left hip against the mother's sacrum, potentially restricting abduction a bit more.
Fascinating. And what about both hips?
Bilateral cases, both hips affected, happen in about 20% of instances.
1 in 5, okay.
And as we touched on earlier, prevalence can vary a bit depending on screening methods used and also population genetics and cultural practices, like swaddling or carrying positions.
Right, that cultural context is key. Okay, let's talk about the clinical picture. What do we actually see or feel when examining a baby or child with DDH? How does it present?
It really varies depending on the age. Let's start with infants under 3 months.
Okay.
Key things to look for are asymmetrical skin folds, like the thigh creases or gluteal folds not matching up, though that can be present in normal babies too, so it's not definitive on its own.
A clue, but not proof.
Exactly. More specific is limited, and importantly, asymmetrical hip abduction. When you gently flex the baby's hips to 90 degrees and try to move the knees outwards.
Abducting the hips.
Yes. You might find one side doesn't go out as far as the other, or feels restricted. Sometimes you might even notice a limb length discrepancy, one leg looking shorter.
And this is where those classic tests come in, Ortolani and Barlow. For our listeners revising, can you give us a quick memory aid for those?
Absolutely. They're crucial for checking hip stability in newborns. Think Ortolani, out to in. It tests if a dislocated hip, out, can be reduced back into the socket.
Yeah.
You'll feel a clunk as it goes back in.
Ortolani, out to in.
Got it. And Barlow, bad hip, maybe? Or backwards?
Oh.
It tests if a hip that's in the socket can be provoked to dislocate or subluxate backwards out of the socket. You're looking for instability.
Barlow, checking if it can dislocate. Okay, those are helpful. Any specific measurement for that limited abduction?
Yeah, a useful guide is if you can't abduct the hip beyond about 60 degrees when it's flexed at 90 degrees. That should definitely raise suspicion for dislocation or significant dysplasia. Less than 60 degrees is a warning sign.
Less than 60 degrees. Okay. What about slightly older babies, say 3 to 6 months? What changes?
You'll likely still see that unilateral limitation and asymmetry of abduction. If the hip has been dislocated for a while, it might now feel more fixed in that position. The Barlow and Ortolani signs might become less obvious or disappear as the hip becomes less reducible.
So the clunks might go.
They might, yeah. But the Galeazzi sign often becomes more apparent.
Galeazzi sign. Remind us.
That's when you lay the baby supine, bend their knees to 90 degrees with feet flat on the table. If one knee appears lower than the other, it suggests the femur on that side is shorter, likely due to a posterior hip dislocation.
Ah, the apparent leg length difference shown by knee height.
Exactly. You might still see the asymmetric skin folds too. And later findings, as they start bearing weight, can include buttock flattening on the affected side, or maybe holding the affected leg in external rotation when standing or walking.
Okay, and if it's missed or presents later in older children?
In older walking children, the key sign often remains that limited abduction when the hip is fully flexed. They might present because they're walking on their toes on one side.
Trying to compensate.
Yes, for the leg length discrepancy. Or they might just have a painless limp.
A painless limp, that's important. And we mentioned bilateral cases, about 20%. How do they present? They might look symmetrical, right?
They can, yes, which makes them trickier to spot sometimes. You won't necessarily have the asymmetry or the positive Galeazzi sign.
So what clues are there?
You might notice a characteristic waddling gait once they start walking. And often there's marked hyperlordosis, an exaggerated inward curve of the lower spine.
Ah, the waddling gait and back arching.
Exactly. It really highlights why you need a high index of suspicion and a thorough examination every time, even if things look symmetrical initially.
Good point. And it's worth stressing again, DDH is an evolving process, isn't it? A normal exam at birth doesn't completely rule it out.
Absolutely not. That's why the repeat check at 6-8 weeks is so important.
Mm-hmm.
And while those skin folds are a prompt, remember they're common normally. The skilled physical examination, those specific maneuvers by someone experienced, that's really the primary screening tool.
Okay, so the hands-on exam is vital. What investigations follow if you are suspicious? What about imaging?
Imaging is definitely the next step to confirm or clarify. For infants, particularly under about 4 to 6 months, ultrasound is the gold standard.
Ultrasound. Why ultrasound early on?
Because much of the hip socket and the femoral head is still cartilage in young babies, which doesn't show up well on X-ray. Ultrasound lets us see those cartilage structures clearly, assess the shape of the acetabulum, the position of the femoral head, and crucially, assess stability dynamically.
Dynamically.
Yeah, we can actually perform stress maneuvers, similar to Barlow, while watching on the ultrasound screen to see how stable the hip is in real time.
Okay, that makes sense. So when do X-rays come in?
X-rays become much more useful once the ossification center of the femoral head appears, that bony part starts to form, usually around 4 to 6 months of age. Then we can draw lines and measure angles on the X-ray to assess alignment and dysplasia.
So ultrasound first, then X-ray later, usually. What about MRI?
MRI isn't typically used for initial diagnosis. It's more for complex cases, maybe if the ultrasound or X-ray is unclear, or often for preoperative planning if surgery is needed, as it gives fantastic detail of both bone and soft tissues. The downside is it often requires sedation or general anesthesia for young children.
Right, sedation is a factor. Okay, let's talk screening again. You mentioned the newborn and 6 to 8 week checks. Is there universal screening beyond that?
Well, the clinical examination is the universal screen at those time points.
Yeah.
Universal ultrasound screening for every single baby is generally not recommended in the UK and many other places.
Why not? Wouldn't it catch everything?
The evidence is actually quite mixed on whether it leads to better overall outcomes compared to selective ultrasound based on risk factors and good clinical screening. There's a risk of overdiagnosis and overtreatment of hips that might have stabilized on their own.
Oh, okay.
What we do know is that careful clinical screening by experienced examiners is effective at reducing the number of late presentations, which are harder to treat.
So targeted ultrasound based on risk makes more sense. What are those triggers for getting an ultrasound?
Yes, selective screening is the approach.
Oh.
Key indications for ultrasound include a first-degree family history of hip problems requiring treatment,
Okay.
breech presentation at or after 36 weeks gestation, regardless of how they were delivered,
Right.
or breech presentation at delivery if the baby was born before 36 weeks,
Got it.
and also in multiple births if any of the babies meet those breech criteria.
Okay, clear indications there. Any other investigation points? You mentioned arthrography.
Yes, arthrography is usually done in the operating theater. It involves injecting contrast dye into the hip joint under X-ray guidance. It's often used right before a planned reduction surgery to assess the obstacles to getting the hip back in place, and helps decide between trying a closed reduction versus needing an open surgical approach.
Okay, so that's more of a perioperative tool, right? We found DDH, confirmed it. What happens next? What's the management strategy?
The absolute key is early diagnosis and prompt treatment for the best outcomes. It's interesting, many hips that feel a bit unstable right at birth will actually stabilize spontaneously within the first, say, 2 to 6 weeks.
Oh, really? So not all instability needs immediate treatment?
Not necessarily immediately, especially if it's just mild instability. But if a hip is clearly dislocated or remains dislocatable after those first few weeks, then yes, intervention is needed promptly.
So what's the first line of treatment non-surgically?
For infants diagnosed early, typically under 6 months, the primary treatment is usually a dynamic flexion-abduction orthosis. The most common one is the Pavlik harness.
The Pavlik harness, how does that work?
It's a soft brace with straps that holds the baby's hips in a specific position, flexed up like knees towards the chest, and abducted, so knees spread apart, kind of like a frog leg position.
Okay.
This position aims the femoral head towards the acetabulum and encourages the socket to deepen and develop more normally around the ball. It allows movement, which is important, but prevents the hip extending or adducting, which could allow it to dislocate.
And when do you start it?
As soon as the diagnosis is confirmed, ideally. It can be adjusted as the baby grows. Its effectiveness is highest when started early, ideally before 3 months, and it becomes less likely to work successfully if started much after 6 to 8 weeks of age, or certainly after 6 months.
So time is really of the essence with the harness. What if the hip is stable, but just mildly dysplastic on ultrasound?
That's a situation where observation might be appropriate initially. For stable hips with mild sonographic dysplasia, guidelines often suggest monitoring for about 6 weeks and then reassessing, perhaps with another ultrasound, before deciding if active treatment like a harness is needed.
Okay. And when does surgery enter the picture?
Surgery is generally indicated if the Pavlik harness or other bracing fails to achieve or maintain a stable reduction of the hip, or if the diagnosis is made later, typically after 6 months of age when the harness is less effective or contraindicated.
What kind of surgery?
For infants, say between 6 and 18 months, the first step is often a closed reduction under anesthesia. The surgeon manipulates the hip back into the socket without making a large incision. This is frequently combined with an adductor tenotomy.
Releasing a tight tendon.
Exactly. Releasing the tight adductor tendon in the groin to make it easier for the hip to stay in place. After the reduction, the child is typically put into a hip spica cast, a large body cast covering the waist down to the ankles for several weeks or months to hold the hip securely.
Okay. And for older children?
If DDH is diagnosed even later, say after 18-24 months, or if closed reduction fails, then open surgery is usually required. This involves making an incision to directly visualize the joint, remove any obstacles preventing reduction, and repair the joint capsule. Often, this is combined with bony procedures called osteotomies.
Osteotomies, cutting and reshaping bone.
Precisely. Either the pelvis, pelvic osteotomy, or the femur, femoral osteotomy, or sometimes both, might need to be surgically reshaped to improve the alignment and stability of the hip joint. These are more extensive procedures.
And how do surgical outcomes compare?
Generally, the younger the child is at the time of surgery, the better the potential outcome. Poorer outcomes are associated with older age at surgery and significant potential complications like osteonecrosis damage to the blood supply of the femoral head or redislocation after surgery.
Osteonecrosis sounds serious.
It is. It was one of the main concerns with DDH treatment, both non-surgical and surgical, though rates vary.
Okay, so after treatment, whether harness or surgery, what's the follow-up plan?
Follow-up is absolutely crucial. It needs to continue until the hip is confirmed to be clinically stable, and imaging, usually x-rays by this point, shows a well-centered femoral head within a normally developing acetabulum.
How long does that take?
It can take years. There's actually ongoing discussion about exactly how long follow-up should continue and how often x-rays are needed. It's important because sometimes acetabular dysplasia can persist or even develop later, even in the initially good hip.
So you need to keep checking both hips.
Yes, monitoring development is key. So just to summarize management, it really depends on age and severity. Options range from observation for the mildest stable cases to the Pavlik harness as first line for young infants, potentially traction in some centers, then closed or open reduction surgery, often with casting or bracing afterwards, and sometimes complex osteotomies for older children or complex cases. Remember those contraindications for the Pavlik harness too, generally not used over 4.5 to 6 months old, or if the hip is irreducible.
That's a great summary. So overall, what's the prognosis if it's caught and treated properly?
The prognosis is generally favorable, especially with that early detection and appropriate management starting in infancy. The vast majority of children treated early go on to have normal functional hips.
That's really good to hear. Now, can we do anything to actually prevent DDH?
Well, we can't prevent the underlying predisposition, but primary prevention efforts focus heavily on education about safe infant handling practices, particularly safe swaddling.
Right, you mentioned swaddling earlier. What are the guidelines?
The key advice from organizations like the International Hip Dysplasia Institute and POSNA is that when swaddling, the hip should be allowed to be in slight flexion and abduction, bent and spread apart naturally.
The frog leg position.
Exactly. The swaddle should be loose around the legs and hips, allowing free movement towards that position. What you absolutely must avoid is forcing or holding the baby's hips into extension, straight, and adduction together for prolonged periods, especially in the first few months. That tight, straight leg swaddling is a known risk factor.
So hip-healthy swaddling allows leg movement. That's vital info for new parents. Now, despite best efforts, what are the potential complications we might see?
With treatment, particularly surgery, potential complications include redislocation or residual instability, joint stiffness, excessive blood loss during surgery, infection, nerve injury, though rare, and that vascular necrosis, AVN, of the femoral head we mentioned.
AVN again. What's the risk level for that?
Reported rates vary quite a bit depending on the study, the age, and the treatment, but it's often quoted in the range of 5 to 15%. It's a significant concern because it can lead to long-term problems like deformity and arthritis.
And the long-term impact of DDH itself, if not perfectly treated?
Well, as we said, it's a major cause of childhood disability and leads to that high proportion of early hip replacements, up to 9% of all primary hip replacements, and 29% in those under 60.
Significant numbers.
Yeah. And long-term, even if treated, there can be an increased risk of premature degenerative joint disease, osteoarthritis, in the affected hip later in life. Some people might also develop related issues like low back pain due to altered biomechanics over time.
So the message really is screen carefully, diagnose early, treat appropriately, and follow up diligently.
That's the bottom line. Early recognition and effective management truly make a world of difference for long-term hip health and mobility.
This has been incredibly insightful, a really thorough deep dive into DDH. Thank you. For everyone listening, especially if you're revising, hopefully that's helped solidify the key points. And don't forget, for more resources and practice questions, you can check out pastthemsarray.com and freemsra.com.